Hi, anatomy students. Welcome to the final module. We'll start out with chapter 22, which is on the respiratory system. Again, there's lots of slides in this PowerPoint, so I'll focus on the things you should know. But whenever you're studying kind of any topic in anatomy, be sure you're focusing on identifying all the structures and knowing all the parts in the system that we're talking about, because that's a lot of anatomy, or most of anatomy is just identifying and understanding where all these structures are in the body. So the basic functions of your respiratory system are to supply your body with oxygen and then dispose of carbon dioxide. So we inhale oxygen that our body cells need to create energy, and then we exhale carbon dioxide, which is a waste product of that energy process. There's 4 processes involved in respiration or breathing: pulmonary ventilation, external respiration, the transport of respiratory gases, and internal respiration. And we'll go through those processes as we talk about the anatomy of the respiratory system. So your respiratory organs are the nose, the nasal cavity, the paranasal sinuses, the spaces in the skull surrounding the nasal cavity, the pharynx, larynx, and trachea, bronchi, and smaller branches, and the lungs and alveoli. So you should understand well the major respiratory organs and how they are labeled here. The pharynx is just another word for your throat, and you have different parts of the pharynx. The part that's behind the nasal cavity is called the nasopharynx. The oropharynx is behind the oral cavity, and the laryngopharynx is behind the larynx. And those are all parts of the pharynx, or your throat. The larynx refers to the voice box, which is the first part of your trachea that air will go down, and then it will continue down as the trachea, or the windpipe. And you'll notice here that behind the larynx is your esophagus, where all your food goes. Your trachea will split at the carina, and then it'll split to go into the right and left lungs. The lung is a little bit different shape because it has a little notch here where your heart will sit. And then you can see the diaphragm below your lungs, which is the most important muscle used for breathing. So we can divide the organs of the respiratory system into the conducting zone and the respiratory zone. The conducting zone is the respiratory passageway that conveys air. It will filter, humidify, and warm incoming air. And the respiratory zone is the site of gas exchange, so where oxygen goes into your capillaries and carbon dioxide gets unloaded. And this will include structures that have alveoli. The nose provides an airway for respiration, moistens, warms, filters the air. It's a resonating chamber for speech. So that's why if you have a nasal infection or you have a cold, you sound a little funny, because your nose helps with speech, and it houses all your olfactory receptors that help you smell. The size variation is due to nasal cartilage differences. So the front part of your nose is all cartilage, and we all have different sizes and shapes of nose. The skin of the nose is thin and contains many sebaceous glands. And you can see here the external parts of the nose and what makes it up. I don't think I'll ask you too many specifics about the anatomy of the nose specifically. The nasal cavities, the external nares are your nostrils. They are divided by a nasal septum. It's continuous with a nasopharynx, which is the part of the throat in the back of the nasal cavity. And there's posterior nasal apertures called choanae. There's 2 types of mucous membrane, the olfactory and respiratory mucosa in the nose. So this is a look at the upper respiratory tract coming in through the nasal cavity, the nasal concha. The nasal meatuses are the spaces between the concha. The posterior nasal aperture is where kind of the nasopharynx meets up with the nasal cavity. Here's the nasopharynx. The uvula is the little kind of boxing bag in the back of your throat, looks like the teardrop. Here's the oropharynx, the place of the pharynx behind the oral cavity, and the laryngopharynx is the place behind the larynx. Here's the epiglottis. This is a flap of cartilage that will close and cover the larynx or the trachea when you swallow food, so that food goes down the posterior esophagus instead of into the larynx and the trachea. The respiratory mucosa consists of pseudostratified ciliated columnar. There's goblet cells. There's an underlying layer of lamina propria that contains mucus and serous cells. There's cilia of the epithelium that moves anything contaminated in the mucus posteriorly to the pharynx. The filtered particles and mucus will be swallowed and are eventually digested by the digestive juices in the stomach. And you have sensory nerve endings from cranial nerve number 5 that supply the respiratory mucosa. You have superior, middle, and inferior nasal concha that project medially from the lateral wall of the nasal cavity. These help to deflect particulate matter to the mucus-coated surfaces. They help to filter, heat, and moisten the incoming air, as well as during exhalation to moisture and heat. So to kind of keep in moisture and heat while you exhale the air. Paranasal sinuses are located within your frontal, maxillary, sphenoid, and ethmoid bones. The sinuses open into the nasal cavity. The pharynx then is the funnel-shaped passageway, also known as the throat. It connects your nasal cavity and mouth. It's divided into those 3 sections, and the type of mucosal lining changes along its length. The nasopharynx is superior to the point where food enters. It's only an air passage, and it's closed off during swallowing. The uvula reflects superiorly, and I'll show you how that happens. The nasopharynx has different tonsils that you can read through there. The oropharynx then is behind the oral cavity. It has arch-like entranceway called fauces, has stratified squamous, and there's 2 different types of tonsils in the oropharynx. The laryngopharynx is a passageway for food and air. It contains stratified squamous. It's continuous with your esophagus and larynx, and it extends to the inferior boundary of the cricoid cartilage. Then the larynx extends from the 4th to 6th cervical vertebrae. It's also known as the voice box. And inferiorly, it's continuous with the trachea. The larynx has 3 functions. It helps to produce sound with your voice box and vocal cords. It provides an open airway, and it routes air and food into the proper channels. So the superior opening is closed during swallowing so that food goes down the esophagus, and it's open during breathing so that air goes down the trachea. And it's made up of 9 cartilages. The thyroid cartilage forms the laryngeal prominence, or the Adam's apple. That's more prominent in men because during puberty, testosterone makes their Adam's apple or thyroid cartilage stick out more. And there's other 3 pairs of cartilages, and the epiglottis tips inferiorly during swallowing. The vocal ligaments of the larynx, you have vocal folds and vestibular folds. The vocal folds are your true vocal cords that act in sound production. The rima glottis is the medial opening between vocal folds, and the glottis is the rima glottis and vocal cords together. The epithelium of your larynx starts off as stratified squamous and then continues down as that pseudostratified ciliated columnar. And this is often the epithelium that we associate with the respiratory tract organs, especially moving down into the trachea and some parts of the bronchioles. So here's some of anatomy of the larynx that you can see. Here's your thyroid cartilage, the hyoid bone, then the epiglottis. Here's the epiglottis. It kind of looks like the shape of a tongue. And again, it will close off the larynx when you swallow food so that food does not go down your trachea. So here's a side view. You can see the epiglottis here, and then how it will kind of flap over and close over the larynx when you swallow. Here are your false vocal cords and your true vocal cords, which help to produce sound. And here's a better look at the movement of vocal cords and how they will open and close to resonate and vibrate in order to produce sound. Males have longer vocal cords, and that gives them a lower or deeper pitched voice. And the length of the vocal cords, again, will increase in length during puberty due to testosterone. Voice production, the length of the vocal cords changes with pitch. The loudness depends on the force of air across the vocal cords. And that's about all you need to know about voice production. The trachea then continues to descend into the mediastinum. C-shaped cartilage rings keep the airway open. They're made of hyaline cartilage. Trachealis is located between the open ends of the C-shaped cartilage rings along the length of the posterior trachea. And the carina or carina is the marks where the trachea divides into 2 primary bronchi to go to either lung. And again, the pseudostratified ciliated columnar continues as the epithelium. So here's a look at the type of pseudostratified ciliated columnar. It has goblet cells to create mucus to trap anything harmful that we breathe in, and the cilia will help to move the mucus along. And here's a cross-section of the trachea and the esophagus. You can see how the esophagus is a little bit more bendable, and it can fold or collapse. But the trachea is constantly held open by these C-shaped cartilaginous rings, and those are in blue. And the C-shaped cartilaginous rings keep your trachea open so that air is constantly flowing into the lungs. The bronchial tree is then the extensively branching respiratory passageways. Primary bronchi is the main bronchi. This is the largest. The right main bronchi is a little bit wider and shorter than the left. And you can see them coming down here. The trachea will divide into these left and right main bronchi. And then when it divides again, it's called secondary bronchi or lobar bronchi because it's going to the lobes. Segmental or tertiary bronchus goes to the segments of each lobe. And you can see here that the right lung has a superior, middle, and inferior lobe, while the left lung just has a superior and inferior lobe. So it only has two lobes on the left side because there's a space for the heart right there on the left side. Here's the bronchi of the conducting zone. You can see the mucosa, the pseudostratified epithelium, the lamina propria, the cartilage plate, and smooth muscle. So here are the bronchi in the conducting zone and how they will branch: secondary, tertiary, and bronchioles. Secondary branch 3 on the right and 2 on the left, and it's because the right lung has a superior, middle, and inferior lobe, and the left lung just has a superior and inferior lobe. Then it branches into tertiary or segmental bronchi into each lung segment, into little bronchioles, which are little bronchi, and then the terminal bronchioles are the smallest, and the terminal bronchioles are eventually where it'll change into these alveoli, these sacs. So the bronchial tree changes in tissue composition. We start with C-shaped cartilaginous rings. They're eventually replaced by cartilage plates. Epithelium changes. Initially, it's that pseudostratified ciliated columnar, but it's eventually replaced by simple columnar, then simple cuboidal. Smooth muscle becomes very important because the smooth muscle will help to widen the bronchioles with sympathetic stimulation and constrict under parasympathetic direction. And it's important because remember, your sympathetic nervous system is your fight or flight response. So you want your airways to open to try to get as much air and as much oxygen into your lungs as possible during a fight, emergency, flight response. But during parasympathetic division, they will constrict because you don't need as much air or oxygen during that. I'm recording this early in the morning, that's why I'm drinking coffee. The respiratory zone then consists of all the air exchanging structures. The respiratory bronchioles are where gas exchange occurs, where smooth muscle will be absent. They will branch from terminal bronchioles. They will lead to alveolar ducts and eventually alveolar sacs. Here's the structures of the respiratory zone. So you can see the terminal bronchiole, then the respiratory bronchioles ending in these alveolar sacs. And these alveolar sacs, they look like little grapes kind of clustered together. They are covered with capillaries, and this is where gas exchange will occur. So here is the alveolar duct leading to the alveoli, and the alveolar sac is all of them together. The alveoli then, you have about 400 million alveoli, which account for the tremendous surface area for gas exchange. The surface area of alveoli is equal to about 1,500 square feet, which is important for respiratory gas exchange. You have the structure of alveoli. You have type 1 alveolar cells. Let's see, I think this should be type 1 alveolar cells, which is a single layer of simple squamous epithelial cells surrounded by alveolar basal lamina. So you have different structures. These are type 2 alveolar cells, and type 2 alveolar cells are scattered among the type 1 alveolar cells. They're more cuboidal, and type 2 alveolar cells secrete surfactant, which reduces the surface tension within the alveoli so that they can stay inflated. So again, type 2 alveolar cells are the ones that secrete surfactant, and that might be a test question, we'll see. The structures of alveolar, there's alveolar macrophages, which help to remove the tiniest inhaled particles. They migrate into the bronchi. So here's a look at the alveoli in the respiratory membrane. So you see the terminal bronchioles coming down into respiratory bronchioles and ending in the alveolar sacs. The alveoli are covered with capillaries because the capillaries are where oxygen will come into the capillaries and where carbon dioxide will go into the alveoli. And they're coming to and from the heart. So here's a look at a scanning electron micrograph of pulmonary capillary casts. Here's a look at the detailed anatomy of the respiratory membrane. So you can kind of see here the alveolar sac, and you can see the red blood cells in the capillaries. And here we kind of look at the alveolar and the capillary and where they come together. And you can just see here the direction that oxygen and carbon dioxide go. So oxygen will enter into the blood and carbon dioxide will be offloaded into the alveoli, and then we will exhale that carbon dioxide. The features of the alveoli surrounded by elastic fibers, interconnected by alveolar pores. The major landmarks of the lung, you should know the apex, the base, and the hilum and the root. So you should know well these structures and what they signify. And I'll let you read through those on your own. The left lung, again, the amounts of lobes, it has just two, superior and inferior. It does have the cardiac notch, which is the depression that accommodates the heart. And the right lung has 3 lobes with different fissures. So here are some anatomical relationships of organs in the thoracic cavity, which you should, again, understand well, and the different lobes of the lung. So here is the hilum, which is the area where everything enters and exits the lung. Here's a look at the bronchopulmonary segments, so how it divides into the primary bronchi and then segmental and tertiary segments. So you can see the segmental bronchi highlighted there. Blood supply and innervation of the lungs. So pulmonary arteries, remember, they come from the heart to deliver oxygen poor blood to the lungs, and the pulmonary veins will pick up oxygen and carry the oxygenated blood back to the heart. And then it's innervated by sympathetic and parasympathetic fibers. Parasympathetic and sympathetic, again, parasympathetic will bronchoconstrict and sympathetic will bronchodilate. So here's a cross-section, and it's sometimes nice to see the cross-section of the organs of the thoracic cavity to see how everything is related to each other. Again, one thing to note is that the esophagus is always posterior to the trachea, so it'll be closest to the vertebrae. The pleura then is the double-layered sac surrounding each lung, the parietal and visceral pleura. The parietal pleura lines the body cavity, and the visceral pleura lines the lungs itself. The pleural cavity then is the potential space between the visceral and parietal pleura. And the pleura help divide the thoracic cavity into a central mediastinum and lateral pleural compartments. And you can see here the parietal pleura, the parietal cavity, and the visceral pleura of the lungs. Here's the bronchopulmonary segments. You don't have to know all of the segments, just know that we divide the lung into different segments as each bronchi divides and brings air to that particular segment. You can see here the position of the lungs and the pleural cavities in reference to the thoracic cage. There's 2 phases of pulmonary ventilation, then inspiration or inhalation, and expiration is exhalation. Inspiration is when the volume of the thoracic cavity increases and we have a decrease in internal gas pressure. The main action of the diaphragm during breathing in or inhaling is the diaphragm flattens, and the action of the intercostal muscles, the contraction will raise or make the rib cage larger. Deep inspiration requires these muscles. Quiet expiration is a passive process. Everything relaxes, the diaphragm moves back up superiorly like a cone, and the volume of the thoracic cavity decreases. And then forced expiration is more active, where you forcefully exhale, and it's produced by the contraction of these muscles. So here are the changes in the thoracic volume and the sequence of events during inspiration and expiration. I might ask you one question about which muscles are involved in inspiration and which are involved in expiration, but only expect maybe one question about that. Then we have disorders of the lower respiratory structures. Bronchial asthma is a type of allergic inflammation where we have a hypersensitivity to irritants in the air or to stress. Asthma attacks are characterized by a contraction or a constriction of bronchial smooth muscles and also a secretion of mucus in the airways. Cystic fibrosis is inherited genetically. The exocrine gland function is disrupted, and the respiratory system is affected by this oversecretion of viscous mucus. Chronic obstructive pulmonary disease, COPD, is where the airflow into and out of the lungs is difficult, usually due to emphysema or chronic bronchitis, and usually smoking can play a role in this. So here we have the pathogenesis of COPD. Tobacco smoke, air pollution can lead to continual bronchial irritation, inflammation, or the breakdown of elastin in connective tissue in the lungs. So this continual bronchial irritation is chronic bronchitis, where we get excess mucus production, a chronic productive cough. Emphysema is where we have the destruction of alveolar walls and a loss of lung elasticity, but they both will lead to airway obstruction, air trapping, dyspnea, so problems in breathing, and frequent infections. Here's a look at a normal lung, the alveoli, and alveoli of the lung of a patient with emphysema. So we just have lost kind of our alveoli. And if we don't have the alveoli in elastic tissue, we're not getting proper gas exchange. So oxygen isn't getting into your capillaries. Aging of the respiratory system, the number of glands in the nasal mucosa declines, the nose dries out, it produces more of a thickened mucus, the thoracic wall becomes more rigid, the lungs lose elasticity, and oxygen levels in the blood may fall as well. Thanks for listening to chapter 22, and we'll see you for the next chapter.